Chapter 16, the hand. I will warn you that the hand can seem overwhelming, and I'm sure from the length of this video you're already feeling that, but take a deep breath. We're going to get through it, and we're going to break the hand down in lab in a little bit easier fashion as well. So the hand consists of the palm, four fingers, and a thumb. And it's important to remember that all thumbs are fingers, but not all fingers are thumbs, because the thumb has different positioning in the hand relative to the other fingers. Remember, it is rotated so that it moves in different planes than the other fingers. And the thumb also only has one IP joint. It does not have a distal and a proximal IP joint. The thumb is unique in orientation and motion, so it's addressed separately. The upper extremity functions to position the hand for grasp and manipulation of objects. So the reason we have a wrist and elbow and shoulder is so that whatever we put in our hands can go to the place that it needs to go. We have two types of grasp. We have power grasp and precision grasp, and we'll talk about each of those. Joints and bones of the hands. So if we start with our forearm, we can see our radius and our ulna there, and then we have our carpal bones. Between our carpal bones and our metacarpals, we have our CMC joints, or our carpometacarpal joints. Between our metacarpals and our phalanges, we have our metacarpophalangeal joints, or our MCP joints. And then we have our interphalangeal joints. With the thumb, we only have one IP joint because we only have two phalanges. But with the other four fingers, we have a proximal and a distal interphalangeal joint because we have three phalanges for those fingers. The CMC joint of the thumb, or the carpometacarpal joint, our first carpometacarpal joint, the starting position for the thumb is resting on the anterior surface of the second metacarpal, and this is important for when we get into range of motion of the hand. And remember, we will worry about this more in lab. The CMC of the thumb is referred to as a triaxial joint and a saddle joint because we have both a convex and concave surface on each surface of the joint. So because the thumb is rotated, we have to remember that it moves different than the rest of the limbs in our body. So thumb flexion is when we bring the thumb across the palm. Thumb extension is bringing the thumb away from the palm. Thumb abduction is coming away from the second metacarpal, and so we make kind of that Pac-Man grasp with thumb abduction. Thumb adduction is return to that starting position. And then we also have a special movement with the thumb as known as opposition, and that is reaching the thumb across the palm. Reaching to the base of the fifth metacarpal is going to be full opposition, but we consider opposition anytime we bring the thumb across to any of the other fingers. And reposition is going to be moving from opposition back to that neutral position. Because of that unique orientation, the thumb CMC joint has flexion and extension occur in a frontal plane about a sagittal axis. So we have 0 to 15 degrees of CMC flexion and 0 to 20 degrees of CMC extension. Our neutral position on the goni is not going to line up at 0 when we take range of motion measurements of the thumb, and so we will have to do math. Abduction and adduction of the CMC joint of the thumb occur in a sagittal plane about a frontal axis. We have 0 to 70 degrees of abduction and 0 degrees of adduction because that's the return to neutral. Opposition is a combination of movements or motions in a horizontal plane about a vertical axis. And reposition is the return from opposition. Our arthrokinetics, flexion and extension, has a concave surface moving on the convex surface. So the roll and glide happen in the same direction. So for thumb flexion, we would have a medial roll and glide. For thumb extension, we would have a lateral roll and glide. For thumb abduction and adduction, the convex surface is moving with the roll and glide happening in the opposite direction. And it's important to remember that this is happening because of that saddle shape of the joint. And so it's still an open chain motion that we're talking about, but because of the saddle shape, we have a convex area in one space and a concave area in another space on the same side of the articulating surface. So for thumb abduction, we see a lateral roll and a medial glide. Abduction would bring the thumb forward, so we see an anterior roll and a posterior glide. Adduction is going to see a posterior roll and an anterior glide as we return to that neutral position. We can see we have a lot of movement at the CMC joint of the thumb, but the CMC joints of the fingers have very minimal motion because of their orientation and positioning. So we're not going to talk too much about measurements of those because we don't have to worry about how much they move. Moving distally into the hand, the MCP joint of the thumb, or the metacarpophalangeal joint of the thumb, is going to be where the metacarpal articulates with the first phalanx of the thumb, and this is a synovial uniaxial joint where we get flexion and extension only, and those occur in a frontal plane about a sagittal axis, again because of the position of the CMC joint of the thumb. During flexion, the first phalanx rolls and glides medially. During extension, the first phalanx rolls and glides laterally. We have 0 to 50 degrees of MCP flexion and 0 degrees of extension as we return to the neutral position. The MCP joints of the fingers are a little bit less restrictive than the MCP joint of the thumb because these are biaxial joints. So we get motion in two planes of movement. They are synovial joints as well, and they are condyloid. So flexion and extension occur in a sagittal plane about a frontal axis, same as our other joints of the body. Ab and adduction occur in a frontal plane about a sagittal axis. When we talk about ab and adduction of the fingers, we utilize our middle finger as the reference point. So when we bring our fingers closer together, closer towards the middle finger, we are adducting. When we separate our fingers, we are abducting. It doesn't have any reference to how the fingers are moving in relation to the body. Our reference point is the middle finger. I'm pretty sure we already touched on this, so I'm not sure why this slide got slid over to here, but the MCP joint of the thumb, remember we have flexion and extension, so we have 0 to 50 degrees of flexion, 0 degrees of extension coming back to that neutral position. Ab and adduction aren't measured because we don't have ab and adduction of the MCP of the thumb. We only have those of the MCP for digits 2 through 5. The distal end of the metacarpal is convex and the proximal end of the phalanx is concave. Jumping back to the MCP joints of the fingers, or digits 2 through 5, we have flexion and extension, ab and adduction. So looking at our arthrokinematic motions, with flexion, the phalanges roll and glide anteriorly. With extension, the phalanges roll and glide posteriorly. So this tells us, since our roll and glide are happening in the same direction, that the proximal base of our phalanges are concave, because if in open chain motion our roll and glide are happening in the same direction, then we have a concave surface that is moving. For ab and adduction, our phalanges roll and glide in the same direction. So for abduction, we have a lateral roll and glide. For adduction, we have a medial roll and glide. These are pictures of our MCP joint motions. So again, we're looking at essentially that first knuckle, what we consider our first knuckle, right, where our hand meets our fingers. And so we're looking at motion that's happening there. We have flexion as the fingers come forward, we have extension as the hand straightens up, we have abduction as the fingers separate, and we have adduction as the fingers come together. Moving distally from there, we have our interphalangeal joints. So remember, our thumb has one IP joint and our fingers have two IP joints, a proximal and a distal interphalangeal joint. The thumb IP flexion and extension occurs in a frontal plane about a sagittal axis, again because of the rotation of the CMC joint. We have 0 to 80 degrees of flexion, and then we have 0 to 20 degrees of extension. So if you look at the last segment of your thumb and you bend at that knuckle in your thumb, you can see where you have hyperextension there. That's that 0 to 20 degrees that we're talking about. The arthrokinematic motion is going to be a roll and glide in the same direction because our distal segment is going to be concave. So for IP flexion of the thumb, we have a medial roll and glide. For IP extension of the thumb, we have a lateral roll and glide. Finger interphalangeal flexion and extension occur in a sagittal plane about a frontal axis. So these are going to be the joints at our second and third knuckle of our fingers. Our proximal interphalangeal joint is going to be our second knuckle, and the flexion range of motion is 0 to 100 degrees there. We have no hyperextension at our PIPs, so our extension range of motion will be 0 for that return to neutral. Our third knuckle, our DIP flexion, we should have 0 to 90 degrees of flexion at that joint, and 0 degrees as we return to neutral for extension, though some people have a few degrees of passive range of motion, and there is an even smaller segment of the population that does have a few degrees of hyperextension for active range of motion. So just circling back to the visual, we can see our CMC joints between our row of carpals and our metacarpals, our MCP joint or our metacarpal phalangeal joint between our metacarpals and our phalanges. Our phalanges then have interphalangeal joints, with the thumb having one interphalangeal joint and digits 2 through 5 having a proximal interphalangeal joint and a distal interphalangeal joint. We touched on the arches of the hand when we talked about the carpal tunnel in the wrist, but we want to talk about the arches a little bit more in depth here. So they're defined as two curved legs in the hand, and each leg has a base and a curved upper portion. And part of the arch that is the apex is what we refer to as the keystone. And the keystone is the portion of the arch that's compressed by the weight of the two legs pushing towards each other at the apex. So these arches in our hand are what allow us to have a cupped position of the palm from the bony structures and the tension in the ligaments. So we have a proximal carpal arch and a distal carpal arch, and then the longitudinal arch that runs between them. And if you try to cup your hand, you can kind of see where those arches line up with the picture shown here. The proximal transverse arch, or the proximal carpal arch, runs from the bases of the metacarpals and the carpal bones. The transverse carpal ligament connects the two legs to create tension for that arching, and the capitate is the keystone of the arch. So the highest point of the arch, or that part where the weight is compressed and the arch is maintained by the keystone, is the capitate carpal. The distal transverse arch, or distal carpal arch, is comprised of the heads of the metacarpals. The metacarpal of the thumb and fourth and fifth fingers form the legs, and then the heads of the second and third metacarpals are the keystone. There isn't a ligament to pull tension here. That tension is arising from the transverse carpal ligament at the proximal transverse arch. Running in between those two arches, we have the longitudinal arch, and so that's going to be our carpal bones articulating with the bases of the second and third metacarpals. The second and third metacarpals and the bases of the second and third proximal phalanges form the legs, and then the heads of the second and third metacarpals are the keystones. Again, we don't have any ligament creating tension, but the shape of these bones and the way that the tension is pulled in that proximal carpal arch is contributing to the cupping shape that we can create with our hand. So if we'll remember that transverse carpal ligament that runs to help create the proximal carpal arch also creates the roof of the carpal tunnel. And so we have the flexor retinaculum that's reinforced by the transverse carpal ligament running over top of that. Remember, this creates an enclosed space that our flexor tendons are running through with our median nerve, and when we have irritation or inflammation within the carpal tunnel, we can get compression of the median nerve that causes numbness and tingling in the median nerve distribution of the hand. You can see the median nerve distribution of the hand in this picture with the parts that are colored in yellow. So we're looking at the lateral aspect of the hand from anatomical position up through the middle of the fourth digit. So everything from the middle of the fourth digit laterally, excluding the very tips, that would be the posterior hand. We'll talk about that in a second. So everything from the middle of the fourth digit lateral is going on the anterior surface is going to be innervated by the median nerve, and that would be the distribution of symptom presentation in patients experiencing carpal tunnel syndrome. The extensor retinaculum covers the extensor tendons on the posterior aspect of the wrist, and if you'll recall from the wrist lecture, the retinaculum serve to prevent bowstringing of the wrist tendons because of the shape of the forearm and then opening back up into the hand and the position of the flexor and extensor muscles with their vertical line of pull. So our extensor muscles, both of the extrinsic and intrinsic of the hand, fan out into what we call the extensor expansion. So you can see lumbricals will go in and insert into the extensor expansion. Our extensor digitorum goes in there, and our interosseous muscles, or interosseous muscles. And the extensor expansion is just basically an extension of connective tissue where we don't necessarily have contractility, but it allows for improved dexterity of the fingers. The web space of the hand is the space between the thumb and the index finger, and that allows us to grasp larger objects. If our thumb were positioned in relation to our second digit the same way that our second digit is positioned in relation to our third digit, we wouldn't be able to reach around to grasp objects, and so that is the purpose of the web space. Flexor digitorum superficialis. So it is named pretty nicely flexor. It's a flexor muscle, so we'll find it on the anterior side of the arm. Digitorum, it goes to the digits, so it's going to flex the digits, and superficialis means that it is a superficial muscle. So our flexor digitorum superficialis originates on the common flexor tendon of the medial epicondyle, the coronoid process, and the radius. It inserts on the sides of the middle phalanx of the four fingers, so not the thumb, but the digits 2 through 5, the sides of the middle phalanx. It acts to cause PIP and MCP flexion, so our proximal interphalangeal joint and our metacarpophalangeal joint flexion, and also contributes to wrist flexion, and it is innervated by the median nerve. Flexor digitorum profundus is going to be flexor digitorum superficialis's buddy. So we've got flexor, it's a flexor muscle, goes to the digits, digitorum, so it's a finger flexor. Profundus is going to be what we look at to mean deep. So superficialis is superficial, profundus is deep, so this muscle lies deeper to our superficialis. It originates from the coronoid process and the proximal 3/4 of the ulna to insert on the distal phalanx of the four fingers, so it runs a little bit further out than our superficialis. It flexes all three joints of the finger because it extends more distally out to that distal phalanx. We get flexion of the DIP, PIP, and MCP, and it's an extrinsic hand muscle, so that means it also contributes to wrist motion because it crosses the wrist, so we get a contribution to wrist flexion. It is innervated by the median and ulnar nerves. So flexor digitorum superficialis is superficial to flexor digitorum profundus, so it means that it lies on top of it. But flexor digitorum profundus inserts more distally to superficialis. So what happens is that those tendons run down through the finger, and we can see flexor digitorum superficialis splits in the tendon, so that flexor digitorum profundus tendon can run through that split. Flexor digitorum superficialis goes to the lateral sides of the middle phalanx, so that we're only contributing to PIP and MCP flexion, but flexor digitorum profundus extends all the way to our distal phalanx, so we can see flexion of our DIP, PIP, and MCP, and remember both contribute to wrist flexion. Flexor pollicis longus. So flexor, it's a flexor muscle. Pollicis is thumb, so that's going to tell us it attaches to the thumb and it probably is going to cause thumb flexion. And longus means it's a long muscle, meaning it probably has a brevis buddy. Flexor pollicis longus originates on the radius on the anterior surface to insert on the distal phalanx of the thumb. It flexes the CMC, MCP, and IP joints of the thumb, so it causes flexion across all three joints of the thumb, and it is innervated by the median nerve as an anterolateral muscle of the forearm. Abductor pollicis longus, so abductor being abduction is the motion, pollicis being thumb. This is going to be our thumb abductor. It originates on the posterior middle portions of the radius, ulna, and interosseous membrane to insert on the base of the first metacarpal, or the metacarpal of the thumb. So it does not travel out as far as our flexor pollicis. It serves to abduct the CMC joint of the thumb and extend the CMC and MCP joints of the thumb. So because it does not extend as distally, and because we don't have abduction at our IP joint of the thumb, or even at our MCP joint of our thumb, we just have abduction at the CMC, we can understand why we don't have as much influence. So abduction of the CMC and then extension of the CMC and the MCP joints because of the line of Poole, and it is innervated by the radial nerve. Extensor pollicis brevis. So this is going to extend the thumb, and it's going to be the shorter version. Extensor pollicis brevis originates on the posterior distal radius and interosseous membrane to insert on the base of the proximal phalanx of the thumb, so that it's going to extend the MCP and CMC joints of the thumb. Being that it is an extensor muscle, that tells us it's on the posterior aspect, and so it's going to be innervated by the radial nerve. Extensor pollicis longus is extensor pollicis brevis's longer friend. So longus meaning long, brevis meaning short. We're still looking at extensor being an extension motion, and pollicis meaning thumb. We're originating on the posterior middle portions of the ulna and the interosseous membrane to insert on the base of the distal phalanx of the thumb. So extensor pollicis longus serves to extend the CMC, MCP, and IP joints of the thumb. Because longus, it is inserting more distally, it has influence over all three joints of the thumb there. And being an extensor muscle, it's going to be located on the posterior side, and it is innervated by the radial nerve. Extensor digitorum, so we've got extensor, extension. Digitorum is digits, so we've got finger extension. Extensor digitorum originates on the lateral epicondyle of the humerus to insert on the base of the distal phalanx of the second through fifth little fingers, or second through fifth fingers. So that's going to be our index, middle, ring, and pinky fingers. Because it inserts at the distal phalanx, it's going to affect all three joints of the fingers. So we extend at the MCP, PIP, and DIP joints of those four fingers, but it also crosses the wrist, so it contributes to wrist extension. It is an extensor muscle, so it's going to be located on the posterior aspect of the arm, and so it is going to be innervated by the radial nerve. Extensor indices. Indices is going to indicate our index finger, so this muscle is going to extend our index finger. We originate on the distal ulna to insert on the base of the distal phalanx of the second finger, so we're extending all the way to the distal phalanx, so we should affect all three joints. Its action is to extend all three joints of the second finger or the index finger, so meaning we're affecting the DIP, PIP, and MCP. And it is an extensor muscle, so it's going to be innervated by the radial nerve. Extensor digiti minimi. Digiti minimi is going to refer to our pinky, so we're looking at extension of the pinky here. Extensor digiti minimi originates on the lateral epicondyle of the humerus via the common extensor tendon to insert on the base of the distal phalanx of the little finger. So distal phalanx means that we're going to affect all three joints. It extends all MCP, PIP, and DIP joints of the little finger, and it is an extensor muscle, so it is innervated by the radial nerve. Your thenar eminence is going to be that big meaty part of your hand underneath of your thumb. And so the muscles that make up the thenar eminence are going to be flexor pollicis brevis, abductor pollicis brevis, and opponens pollicis. And if we remember, pollicis means thumb, then all of these muscles are going to contribute to motion of the thumb. We can see flexor pollicis brevis on the radial side of the hand, connecting to the thumb, composing of the muscles that make up the thenar eminence. The flexor digiti minimi muscle is going to be over on the ulnar side of the hand, and that's going to be a part of the muscles that make up the hypothenar eminence. Flexor pollicis brevis originates on the trapezium and flexor retinaculum to insert on the proximal phalanx of the thumb, so it's not going to impact IP motion. It flexes the MCP and the CMC joints of the thumb, and it's innervated by the median nerve, being on the anterolateral aspect of the hand and forearm. Abductor pollicis brevis on the radial side of the hand there is going to be another one of our muscles that make up the thenar eminence, and it's going to abduct the thumb, whereas abductor digiti minimi is going to abduct the pinky, and it is another muscle that makes up the hypothenar eminence. Abductor pollicis brevis originates on the scaphoid, trapezium, and flexor retinaculum to insert on the proximal phalanx of the thumb. So again, proximal, it's not going to affect the IP joint of the thumb. And we don't have abduction of the IP joint of the thumb. It serves to abduct the thumb at the CMC joint because that is the only joint of the thumb that has abduction, and it is innervated by the median nerve, being on the anterolateral aspect of the hand and forearm. Opponens pollicis is going to be the last of our thenar eminence muscles, and you can see that running towards the lateral aspect of the hand, or the radial aspect of the hand, going towards the thumb. And then we also have opponens digiti minimi. So when we think about bringing our thumb across to our pinky, we can also try to bring our pinky across to our thumb, and that's because of opponens digiti minimi, which is, again, a muscle that goes into the hypothenar eminence. Looking more specifically at opponens pollicis, it originates on the trapezium and flexor retinaculum to insert on the first metacarpal. It opposes the thumb, causing motion at the CMC joint, and is innervated by the median nerve. We've talked about all of these because we've talked about the hypothenar eminence as we went through the thenar eminence, but our hypothenar eminence is going to be the portion of muscles on our hand closer to the ulnar aspect on the anterior palmar portion. So those are going to include flexor digiti minimi, abductor digiti minimi, and opponens digiti minimi. We can see flexor digiti minimi here. This is the same picture from earlier. Flexor digiti minimi originates on the hamate and the flexor retinaculum to insert on the base of the proximal phalanx of the fifth finger. So we're only going to influence motion at the proximal phalanx. It serves to flex the MCP and CMC joints of the fifth finger, and it is innervated by the ulnar nerve because it is on the medial aspect of the hand. Abductor digiti minimi, again, sits opposite of abductor pollicis brevis to make up the hypothenar eminence. It's going to abduct the pinky. It originates from the pisiform and the tendon of flexor carpi ulnaris to insert on the proximal phalanx of the little finger. Its action is to abduct the MCP joint of the pinky, and it is innervated on the ulnar nerve, again because it is on the medial aspect of the hand. Opponens digiti minimi sits in complement to opponens pollicis in the hypothenar eminence. Opponens digiti minimi originates on the hamate and flexor retinaculum to insert on the fifth metacarpal. Its action is to oppose the little finger, so again bringing it towards the thumb, causing motion at the CMC joint of the thumb, bringing them closer together, and it is innervated by the ulnar nerve being on the medial side of the hand. So in between our thenar eminence and our hypothenar eminence, we have our deep palmar group. And those muscles that make up our deep palmar group are going to include adductor pollicis, our dorsal interossei, our palmar interossei, and our lumbricals. And these are going to be all intrinsic muscles of the hand. Adductor pollicis, again, another muscle that's named, telling us what it does. It adducts the thumb, pollicis being thumb. Adductor pollicis originates on the capitate, the bases of the second and third metacarpal, and the distal 2/3 of the palmar surface of the third metacarpal. It inserts on the base of the proximal phalanx of the thumb, and the action is to adduct the thumb at the CMC joint. It is innervated by the ulnar nerve being on the lateral aspect of the hand. Our dorsal interosseous muscles are going to be located on the dorsal aspect of the hand, or the posterior aspect of the hand, and attached to our phalanxes. We have dorsal and palmar interossei muscle, and they serve to move the fingers in ab and adduction. And we're going to look at how each one of those affects. But if we think of muscles on the dorsal side, we get more activation of dorsal musculature when we separate our fingers. So our dorsal interosseous muscles are responsible for finger abduction. Looking at that a little bit closer, our dorsal interosseous muscles originate on the adjacent metacarpals to insert on the base of the proximal phalanx of the index, middle, and ring fingers. Their action is to abduct the fingers at the MCP joint. So dorsal interosseous, abduct the finger. And the dorsal interosseous muscles are innervated by the ulnar nerve. So then looking at the palmar side of the hand, or the anterior side of the hand, our palmar interosseous muscles, again, come from our metacarpals to attach to our phalanges. And we're looking at the motion that occurs for our fingers when we look at motion on the anterior aspect of our hand is that we get our fingers drawing together. We get adduction. And so we can understand that palmar interosseous muscles are going to cause adduction. Our palmar interosseous muscles originate on the second, fourth, and fifth metacarpals to insert on the base of their respective proximal phalanx. They adduct the index finger, ring finger, and middle finger at the MCP joint, and they are innervated by the ulnar nerve. Our lumbricals are what I refer to as the tabletop muscles because of the tabletop exercises you can do with your hand with them. As you can see from this picture, they originate from the tendons of flexor digitorum profundus, and so that makes them a little bit unique in that they do not have a bony proximal attachment. Our lumbrical muscles go and run just deep to our flexor digitorum superficialis, but then attach and run up to attach to our extensor digitorum tendon, and so we get flexion of the metacarpals and extension of the proximal interphalangeal joint because of the line of pull of the lumbricals. So again, if we look at our origin of our lumbricals, that's going to be the tendon of flexor digitorum profundus, and it's going to insert on the tendon of extensor digitorum profundus. So there's no bony attachment for this muscle. The lumbrical muscles cause simultaneous flexion of the MCP joint and extension of the PIP and DIP joints. So we get this tabletop position of our hand where we are flexed at our first knuckle and extended at our second and third knuckles. The innervation for our lumbrical muscles are going to be the median nerve for our first and second lumbricals because they are located more laterally in our hand, and then the ulnar nerve for our third and fourth lumbricals because they are located more medially in our hand. Looking at our posterior hand muscles, we can see that with the exception of abductor pollicis longus and our dorsal interosseae, all of these muscles have extensor in our name. So our posterior hand muscles primarily perform extension motions of the wrist and fingers. Our anterior hand muscles are going to comprise more of our flexor tendons, but then we also have our thenar eminence and our hypothenar eminence. So we have abductor pollicis brevis and abductor digiti minimi, and opponens pollicis brevis and opponens digiti minimi. And then we also have our lumbricals and our palmar interossei on the anterior aspect of the hand. Understanding sensory innervation of the hand is important because of symptom presentation. If a patient complains of numbness and tingling in specific fingers, then we know which nerve is involved and we can figure out how to target where it would be compressed. Compression of the median nerve typically happens at the wrist. Compression of the ulnar nerve typically happens at the elbow. Compression of the radial nerve can happen within the shaft of the humerus, but it can also occur within the forearm. And so understanding where symptoms are presenting can help us understand where to target our interventions. So looking at this picture, we can see the ulnar nerve in pink, and that's going to innervate the medial aspect of the hand on the posterior and anterior parts. So we're looking at the medial half of the fourth digit and all of the fifth digit on the anterior and posterior aspects. Our median nerve is going to innervate the anterior surface on the lateral aspect of the hand, going from the lateral half of the fourth digit over to the thumb. And then it also wraps around to do the tips of the fingers on the posterior aspect for those same fingers. Our radial nerve is going to innervate more of the posterior aspect of the hand as well as the thenar eminence. So the muscles of the thenar eminence are going to be innervated by the radial nerve because of that nerve distribution. The functional position of the hand is going to be where we have our wrist slightly extended with MCP and IP joints slightly flexed and the thumb abducted. So you can see that in this picture here. But this position puts the intrinsic hand muscles at their optimal length-tension relationship. Power grips. So remember at the beginning of this lecture we talked about how we have power grips and precision grips. Power grips are for force, precision grips are for fine motor. Power grips are going to include our cylindrical grip, which is where we have all fingers flexing around with the thumb in opposition, like we are holding onto a cylinder. We also have the spherical grip for our power grips, and that's where the fingers and thumbs abduct around an object, such as the type of grip you use when you're unscrewing a lid from something. We also have the hook grip as one of our power grips, and that's where the fingers hook around but the thumb is not included, and so that grip is coming only from digits 2 through 5. Precision grips, again, these are going to be for fine motor skills, and so we're less concerned about force generation and more concerned about control of movement. So precision grips are going to include our pad-to-pad or pinch grip where one finger is used. We also have our pad-to-pad grip or tripad grasp, which is also called the three-jaw chuck when the thumb and two fingers are used. We have lateral prehension or the pad-to-side grip, where the pad of an extended thumb is pressed into the radial side of the index finger. This is relatively stronger compared to other precision grips, and part of why we utilize it for things like turning keys where we need force in our precision grip. The side-to-side grip is going to utilize the fingers and not the thumb, and we hold between the side of two fingers. And then the lumbrical grip is going to utilize our lumbrical muscles, so we'll have flexion of the MCP with extension of the DIP and PIP joints, and this is a position that we can utilize for things like carrying plates. Tenodesis, we've talked about this a little bit in reference to spinal cord injury patients, and we'll talk about it more in Therex. But spinal cord injury patients with injuries below C6, C7, so they definitely don't have C8, which is going to be our finger flexion motion. These patients can utilize active wrist extension with inherent tightness in the finger flexor muscles to create a grasp, and the increased tension in the finger flexors allow a firmer grasp when that wrist extension is applied. A tenodesis grip intentionally positions the wrist to allow for adaptive shortening of the wrist and finger flexors so that active wrist extension will cause passive flexion of the fingers and allow for a functional grip for ADL performance. It would appear that this video is not going to play no matter how many times I click on that play button. So I'd encourage you to go into your PowerPoint and watch this video. He does a great job demonstrating the functional use of his tenodesis grip. Common pathologies of the hand, so CTS, or carpal tunnel syndrome, we talked about, is compression of the median nerve as it passes through the carpal tunnel with the flexor tendons of the wrist. Compression of that can cause numbness and tingling in the median nerve distribution of the hand. De Quervain syndrome or De Quervain's disease is a tenosynovitis that affects abductor pollicis brevis and extensor pollicis brevis. And we can determine if somebody has De Quervain's by having them tuck their finger in their palm and tuck their thumb in their palm and wrap their fingers around the thumb, and then ulnarly deviate the wrist. And pain within the radial aspect of the hand would indicate a positive test from that one. Dupuytren's contractures is where we have contracture of the palmar aponeurosis, and if you remember, that's the connective tissue that spans the palmar aspect of the hand to cover the extrinsic finger tendons or finger flexor tendons. And those contractures can produce these thickened nodules within the hand over top of the tendons and can limit finger and wrist extension as a result of those contractures. Trigger finger is when we get these nodules within the tendons of the finger flexors, and it causes the person to kind of be jerked into a flex position at the finger that they then have to extend manually. Skier's thumb and gamekeeper's thumb are both sprains of the ulnar collateral ligament, and we can see skier's thumb happen as a result typically of a fall on an outstretched hand, and gamekeeper's thumb is caused by repetitive prolonged hyperextension of the IP joint of the thumb pulling on the hand as well, and it's called gamekeeper's thumb because of carrying game on your thumb that way. Ulnar drift we talked about a little bit when we talked about the effects of gravity, but ulnar drift is where we see this deformity of the hand into an ulnarly deviated position, and this again occurs over time as a result of the effects of gravity. In a functional grasp, gravity is going to pull us into an ulnar deviation. It is also a common presentation in patients with rheumatoid arthritis. Swan neck deformity and boutonniere deformity are also common presentations that we can see in patients with rheumatoid arthritis. Swan neck deformity is going to involve the finger being stuck in an extended position at the PIP and a flex position at the DIP, typically with flexion of the MCP as well. And then a boutonniere deformity is going to be the opposite of that. So that's where we see extension of the DIP and flexion of the PIP. And again, typically MCP flexion as well. And then mallet finger is going to be where we have disruption to the extensor mechanism for our DIP joint, and so the patient has the inability to actively extend at the DIP, and the finger tends to fall into a flexed position at the PIP joint. Because we have finger flexors that cross the wrist and also cross the elbow, we know we have limited impact on the elbow, but we do have the influence of active and passive insufficiency. So we see active insufficiency with full wrist flexion. We get active insufficiency of the extrinsic finger flexors. So if I take my wrist and I flex it all the way forward and try to squeeze my fingers into flexion, I don't have as much force that I can generate as if I put my wrist back to neutral and try to squeeze those fingers. And we can play with the handheld dynamometer in class to see the impacts of that. For full wrist extension, I have active insufficiency of the extrinsic finger extensors, and that's part of why it's harder to straighten my fingers out when I put my wrist in an extended position. For passive insufficiency, we see passive insufficiency of the extrinsic finger muscles that limit motion of wrist flexion when the fingers are flexed. So I get extrinsic finger extensors unable to lengthen sufficiently when my wrist is flexed, and that's a contributing factor to why I cannot fully flex my fingers in that position. And then for wrist extension, again, going back to the tension in my finger flexors, when my wrist is positioned in a fully extended position, the extrinsic finger flexors are unable to lengthen sufficiently, and contributing to why it's difficult to straighten my fingers in a wrist extended position. I do believe this is our last slide for this presentation. I did not put in a before class slide, so please remember before class to review the anatomy of the hand in preparation of performing range of motion and manual muscle testing in lab. Write down any questions you have over this chapter so that we can discuss them in class prior to beginning our lab activities, and make sure that you prepare lab appropriate clothing to expose the wrist and hand for manual muscle testing and range of motion procedures.